Hello, good evening friends. Today we will be discussing about a case of congenital uterine anomaly on which we operated. The anomaly was U2C1V1, that is complete uterine septum with a cervical septum and a longitudinal vaginal septum. But before discussing and showing you the video of the surgery, let us just brush up with what is congenital uterine anomaly, which is also called as Mullerian anomaly. The Mullerian anomaly is named after German physiologist J.P. Muller in 1830, who studied them. Now, Mullerian anomalies are congenital abnormalities of the reproductive tract that result in atypical development of the uterus, fallopian tube, cervix, and/or vagina. Remember, friends, whenever you have a Mullerian anomaly, it is always associated with another anomaly which is common anomaly which is seen is renal anomalies. And in a patient with Mullerian duct anomalies, almost 30% of the patient has got a renal agenesis. The congenital uterine anomalies are nothing but deviations from normal uterine anatomy. The prevalence is 5.5% in general female population, 8% in infertile female population, 13.3% in history of miscarriage, and 24.5% in women with recurrent miscarriage. So the incidence is quite high in recurrent miscarriage. Now let's go to embryology. Now in embryology, the female reproductive tract develops from a pair of Mullerian ducts that forms the fallopian tubes, uterus, cervix, and the upper two-thirds of the vagina. The ovaries and the lower one-third of the vagina have a different embryological origin, that is genital ridge and urogenital sinus respectively. Now what happens, initially there is a formation of Mullerian buds which then migrate down and get fused, and afterward there is a resorption of the septum. Anything going wrong in these three, that is formation, fusion or resorption, or incomplete development, result into various anomalies. Like in the formation, if there is no formation, it can lead to uterine aplasia. If there is an incomplete fusion or there is no fusion, then it can lead to uterine diadelphys or bicornuate. And if there is incomplete resorption or no resorption, it can result into a septate uterus. Now, there are various classifications were suggested. Initially in 1988, the ASRM classification divided these Mullerian anomalies into 7. As shown in this diagram, first is hypoplasia unicornuate, third is diadelphous, fourth is bicornuate, fifth is septate, sixth is arcuate, and seventh is diethyl still-based or drug-related. Now remember, they never took into consideration the cervical anomalies or the vaginal anomalies, that is septate, horizontal septum or a longitudinal vaginal septum. So in 2013, the ESHRE or ESG classification came into play, and it took into account the cervical part also and the vaginal part also. And they, for the uterine anomaly, they divided into 6 categories, starting from U0, which is normal uterus. In the chart you can read that for a normal cervix, it starts from normal cervix C0, and you have a septate cervix, double normal cervix, unilateral aplasia, cervical aplasia. From vagina, they start from V0. So any anomaly, you denominate the U, their number, C, their number, and V, and their number. Now this took into account the vagina and the cervical part also. Now in 2021, the American Society of Reproductive Medicine came with another classification. They classified the Mullerian anomalies into 9 categories: Mullerian agenesis, cervical agenesis, then came the unicornuate, uterus diadelphous, now and bicornuate uterus. If you look at this diagram, the last towards the right side terminal part, there is a one thing which is called as combined bicornuate septate uterus. Please keep that picture in your mind. It's very dicey. Then came the septate uterus, then longitudinal vaginal septum, horizontal vaginal septum, complex anomalies. Now this chart shows you the correlation of ASRM and ESGA classification, which is quite confusing. So what I suggest to the students is that follow any of the classification, but whenever you see such patient or operate on such patient, you should have a precise things written on your discharge paper. Whatever classification you follow, or you may not follow, but you write precisely what have you seen, what is your diagnosis, what have you done to the patient. The most commonly followed classification is ESG classification. Now, It is very important. I will restrict our discussion to the septate and bicornuate uterus. Now, it is very important that to differentiate between a septate and a bicornuate uterus, because septate uterus is the most common uterine anomaly, accounting 35% of the congenital uterine anomalies. And why the differentiation is important? Because hysteroscopic method cannot be used to treat the bicornuate uterus, but it can be definitely used to treat the septate uterus. The ratio of septate to bicornuate is almost 4:1. Now, there are various diagnostic modalities. First is the clinical signs and symptoms. Patient with the congenital uterine anomaly, it comes with the recurrent abortion or infertility or secondary infertility with recurrent miscarriages. So you should always keep in your mind, if such a patient comes to you with recurrent miscarriage and secondary sterility, out of 4 patients, 1 patient has a congenital uterine anomaly. Now, the first diagnostic modality which was used previously was hysterosalpingography, but it's not so good. The rate of false positive results is 38% and the sensitivity is just 44%. In addition, this test cannot differentiate the septate from bicornuate, although certain criteria has been laid down, like intercornual distance. If it is less than 2 cm, it is septate. If it is more than 4 cm, it is bicornuate. Then the intercornual angle, if it is less than 75 degrees, it is septate. More than 105, it is bicornuate. The gold standard previously in diagnosis differentiating between septate and bicornuate was hysterolaparoscopy. Hysteroscopy alone cannot diagnose the two different things, septate or bicornuate, because when you do hysteroscopy, you see 2 cavities as it is. So Betoke's criteria, Professor Betoke devised his own criteria. He did office hysteroscopy, that is without analgesia and anesthesia, and the intervening wall is cut with the scissor. If there is the vascular tissue, that is with the first cut, if there is a bleeding, then it's not a septum, it's a muscle which you are cutting, and it's definitely a bicornuate. If the patient starts shouting with the first cut itself, that is there is sensitive innervation which is always there in muscle, that is it's a bicornuate. If there is the appearance of tissue at the site of incision, that is a pinkish tissue, then it is definitely a bicornuate, not a septum. So these were the criteria laid, which is called as Betoke's criteria. Now, the accuracy of 2-dimensional saline infusion sonography and 3D transvaginal sonography is almost same. However, the 3-dimensional sonography, the 3-dimensional reconstruction it creates of the uterine cavity and the external serosum contour, in addition to the option of coronal plane imaging, allows complete visualization of the uterine cavity in congenital uterine anomaly, and thus offering reliable diagnosis and classification. That is why 3D TVS is much more preferred. And now 3D TVS diagnosis sensitivity and specificity is reaching almost 99%. So we have stopped doing a laparoscopy alone on the diagnosis of a 3D TVS sonography. Now, there are various criteria laid on the basis of the sonography to differentiate between the bicornuate and a septate uterus. The first important is you are supposed to see the external fundal contour. If there is any indentation, then you have to think about it. First, there is the interosteal line. If there is an external fundal indentation, if that apex falls below the interosteal line, 5 mm below or above, it is suggestive of bicornuate. If it is more than 5 mm, then it is a septate uterus, apart from the internal fundal indentation. Now, depending upon which classification you follow, remember one thing, ASRM always talks in terms of centimeter and ESG classification always talks in terms of percentage. Now, these are the various pictures which differentiate between the septum, arcuate and the bicornuate uterus. Now, the uterine wall thickness is measured about the interosteal or the intercornual line. When you talk about the ESG definition, then if the internal indentation is more than 50% of uterine wall thickness, then it is a septate uterus. If the external fundal indentation is more than 50% of the uterine wall thickness, it is a bicornuate uterus. Uterine wall thickness is always measured above the intercornual or interosteal line. Now, this is the diagram. You can go thoroughly through this diagram, and which gives a very nice information about the bicornuate and septate uterus. Now, there is always a confusion between the intercornual line and the interosteal line. Intercornual line is a line connecting the highest point of the endometrial cavity at each side of the uterus. And interosteal line is the distance between the line joining tubal ostia. Now, although some authors suggest using interosteal line, the position of the tubal ostia is frequently unclear, particularly using the standard multiplanar view. Therefore, using this line as a reference would result in several non-measurable cases. Additionally, the interosteal line is sometimes placed below the intercornual line, and using this line as a reference will not reflect the total indentation in these cases. But remember one thing, your sonologist should be smart enough or if you are doing sonography by yourself, you should have only one reference line, either interosteal or intercornual. You can use intercornual line while mentioning the external fundal indentation, and using an interosteal line while mentioning the internal fundal indentation. Use only one line for mentioning both the things. Now, this is the classification by according to transvaginal sonography of the septate and bicornate uterus. Now, most important is the external fundal indentation. Now, this is the diagram we suggest, which gives a classification of a septate uterus of ESG classification and CUME, that is Congenital Uterine Malformation Expert Committee, and ASRM classification. ESG always talk in terms of percentage, but rest of them talks about centimeters. This is the diagram which shows what you are going to see on sonography. The most important is the external contour. If the external contour shows any fundal indentation, measure how deep it is. If it is more than 1 centimeter, it could be diadelphous or bicornate. If it is less than 1 centimeter and if there is no internal fundal indentation, then it is a normal uterus. If their internal fundentation is more than 1 centimeter, it is septate. If it is less than 1 centimeter, it is arcuate. Now, there is a very nice paper which compares the study of three-dimensional transvaginal sonography versus MRI in congenital in the classification of septate and bicornate. And what we have observed is that the three-dimensional transvaginal ultrasonography had a higher specificity compared to MRI in diagnosing bicornate uterus and diaphthalmous uterus. And it has got higher sensitivity for septate uterus also. So with that, we finish the discussion on Mullerian anomalies. Now we'll show you the video of the surgery which we have done it. Thank you.